Very warm welcome to our another edition of weekly PG activity of the Academy of Pediatrics Uttar Pradesh, which is going on for the 1.5 years. Every week, every Friday, 3 to 4 p.m. It's a slot with the PGs await for this activity. We are trying to have the advantage of one of the best faculty members who are expert on this topic to enlighten our postgraduates. There are many times there are case presentations, and sometimes there are some expert classes like this one. And also we have some eminent chairpersons all the time, so that the subject can be thoroughly discussed. And this time also, I welcome and thank our honorable chairpersons, Dr. Shankar Chaurasiya and Dr. D.K. Singh, and our eminent and expert faculty, Dr. Bikrant, who will be talking about the approach to a case of jaundice. I think it's a very interesting topic. Every postgraduate must be looking forward to it. And this is a case which is often you get all the time. And this is a lecture which will be worth preserving. And let me begin before our chairpersons take over by introducing our honorable chairpersons. First of all, Dr. D.K. Singh. He's presently working as a professor and HOD Pediatrics and Dean at the Postgraduate Institute of Child Health, Noida. Earlier, he was a professor and HOD Pediatrics at MLN Medical College, Allahabad. Areas of interest are pediatric infectious diseases, HIV and AIDS, hematology, oncology, and immunology. And he has published 50 papers in national and international journals of repute and contributed chapters in 10 pediatric textbooks. So fairly accomplished and a very distinguished faculty member from Uttar Pradesh. Thank you, Dr. D.K. Singh, for sparing your time and giving your input for the benefits of the PGs. Then
you,
our another chairperson, welcome Dr. Shankar Chaurasiya, who is a very well-known figure of AOP UP. He is currently the EB member of from Uttar Pradesh. Last year also he represented UP. He has been the Honorary Secretary General of UP IAP 2019-21. Currently, he is the Associate Professor and Head Department of Pediatrics at Medical College, Jhansi, and in charge of the Well Baby Clinic, Immunization Center, and the National Trainer from the Cervical Course Immunization Practices, PFHI India, TOT of the CHF, and has been in the various held positions in the Academy of Pediatrics, Jhansi. And has several responsibilities at his head, and a very, very busy person, officer in charge of the building, medical college, president, social society, nodal officer, hemophilia, thalassemia. He has won several awards to his credit: Best President Award among Uttar Pradesh IB branch, Best Breastfeeding, Celebration Award. So many awards to his credit. Just shows how active and passionate he's about for the AOP and a valued member. And I think his inputs, the postgraduates will be benefited. Thank you, Dr. Chaurasiya. Now, with this introduction of honorable chairpersons, I request our honorable chairpersons to please take over the session. And I request Dr. D.K. Singh to please introduce our
thank you, Dr.
honorable speaker, Dr. Bikrant, who has spared his time. Thank you, Dr. Bikrant. Now, over to our chairpersons.
Yeah, thank you, Dr. Salam. I welcome all the PGs and faculty members who have joined this e-learning platform of AOP UP. As we all know that jaundice is very common situation in our country, and especially in this season of rainy season, we have already started seeing patients of viral hepatitis in OPD, as well as cases of acute liver failure and hepatic encephalopathy in emergencies also. So it's very common condition. All the postgraduates must know about it, how to manage on OPD basis, when to admit, and how to manage the patients of ALF. So I invite Dr. Bikrant Bihari Lal, who is DM in Pediatric Hepatology. He is presently working as Associate Professor in Pediatric Hepatology at Center of Eminence, that is ILBS Delhi. And he has 50 publications in the international journals and 3 chapters in books. His area of interest are viral hepatitis and acute liver failure in children, and plus genetic intrahepatic cholestasis. And he has received international and national awards from Pediatric Society on his research on hepatitis B. So he's a very experienced person for the management of jaundice in children. So I invite Dr. Bikrant for starting his lecture, please.
Thank you, sir. So is my screen visible now? Yeah. Thank you. So I'll be starting this. So thank you to the Academy of Pediatrics UP for giving me this opportunity to speak on this vast topic, that is approach to jaundice in children. Now, jaundice, just a second. Yeah. So jaundice is actually just a symptom. So it could be a manifestation of a hepatic disease, or it could be a manifestation of an extrahepatic disease. So when you encounter a child with jaundice in your OPD, the first thing you need to differentiate is whether you are dealing with unconjugated jaundice or you are dealing with conjugated jaundice. And that you can make it on the basis of clinical history taking, that is, you can ask for urine color. A child with conjugated jaundice, that is having conjugated bilirubin, will always have dark urine color, whereas a child with unconjugated jaundice will have normal urine color. And always do the fractionation of bilirubin. Don't just order total bilirubin. Order bilirubin, direct bilirubin, and the whole of liver biochemistry. So you'll find that children with unconjugated jaundice will have only indirect bilirubin with normal AST and ALT. Now, this is a sample. This is a LFT of one of the child who came to us in OPD a couple of months back. Now, you can see the patient complained of jaundice for last 5 months. But when we asked how was the urine color, he said most of the time the urine color was normal. So we did his LFT. We suspected that it could be unconjugated hyperbilirubinemia. We did his LFT and we find that direct bilirubin is only 0.1 out of a total of 7.7. So this is a case of indirect hyperbilirubinemia with absolutely normal SGOT and SGPT that suggests there is no inflammation in the liver, and normal albumin, suggesting that normal liver synthetic functions. So if we have an unconjugated jaundice like what I showed just now, we have to think of two common causes. One is, first and foremost, you have to rule out hemolytic anemia. We all know how we rule out hemolysis. And apart from hemolysis, we should also rule out B12 deficiency. Because of ineffective erythropoiesis in B12 deficiency, these children can also present with jaundice. Once you have ruled out hemolysis and B12 deficiency, what you are left with is congenital disorders of bilirubin metabolism, which include Crigler-Najjar syndrome, which will present in the infancy or in the neonatal period only, and will be more severe and will progress. Type 1 will progress and will require liver transplantation. The second one is Gilbert syndrome. Now, Gilbert syndrome will present to you later as an older child beyond 1 year of life. And what the LFT I just showed some time back was the LFT of a child with Gilbert syndrome. So they will present with, so this is what we have published previously about Gilbert syndrome. The bilirubin you don't expect bilirubin to be very high. It varies between 2 to 5. Direct bilirubin is normal. AST and ALT is normal. And hemolysis has been ruled out in these children. Now, the more important part is the conjugated jaundice. Now, conjugated jaundice could again be disorders of bilirubin metabolism like Dubin-Johnson and Rotor, which are very rare. So what we will concentrate on is liver disease. So all the liver disease will present with conjugated jaundice, which can be in the form of acute liver disease, a chronic liver disease, and among the chronic liver disease, it can sometimes be cholestatic liver disease. So further in this talk, we'll be concentrating only on this part, that is conjugated jaundice due to liver disease. Now, there are two wide spectrum. If you have an infant, the causes of jaundice are completely different. If you have an older child, the causes of jaundice are completely different. So we'll start with the causes of jaundice in an infant. So the term that we use is neonatal cholestasis. That can also be called as conjugated hyperbilirubinemia of infants, or you can also call it infantile cholestasis. Whatever the term, it is mainly defined on the basis of presence of direct hyperbilirubinemia. So whenever you get like say 6 or 7 days, 8 days, 10 days old baby with jaundice, again, always do bilirubin fractionation. Don't just do total bilirubin. And if the direct bilirubin is more than 20% of the total bilirubin, that means you are dealing with neonatal cholestasis, or you are dealing with conjugated hyperbilirubinemia, which is due to a liver disease, and you need to find the cause for it. Again, you will have clinical indicator in form of dark urine, because conjugated bilirubin is excreted in urine. So you'll have dark urine, or you can also ask that urine is very dark, causing diaper staining in the child. So this is from one of the child who is admitted currently with us, 52 days old child. You can see here that the child's total bilirubin is 8, whereas direct bilirubin is 4.7. That is more than 50% is direct bilirubin. So what we are dealing here is a case of neonatal cholestasis. If this was predominantly indirect, we would have said that this was neonatal jaundice, but then that child would have presented quite early to you. So what are the common etiologies of infants with jaundice? The most common and the most important one that we need to remember is an obstruction to the biliary tree. So this is the liver, these are the right and left hepatic duct, this is the common bile duct. The most common cause of conjugated jaundice in an infant or in a neonate presenting to you will be biliary atresia. Now, biliary atresia means the whole of the bile duct from the right and left hepatic duct till the common bile duct will not have a lumen. So it will be completely atretic bile duct. That is called as biliary atresia, and it is quite common. The incidence is 1 in 5,000 to 1 in 10,000 live births in India. Apart from the biliary causes, the biliary obstruction could be due to biliary atresia, or it could be due to some other things which are causing inspission in the bile, like severe hemolysis or sometime parental nutrition. Children who are receiving parental nutrition, especially premature ones who are receiving parental nutrition for a long time, can also develop severe cholestasis causing obstruction to the biliary tree. The second important group of etiologies which cause neonatal cholestasis is genetic causes of intrahepatic cholestasis. So this bile duct obstruction is usually called as extrahepatic cholestasis. And the cholestasis, the bile is formed in the liver, in the hepatocyte. And this bile comes out from the hepatocyte into the bile duct through certain transporters. Now, if these transporters are abnormal, then it leads to cholestasis, which is usually called as PFIC, progressive familial, that is genetic, intrahepatic cholestasis. So these are the second most common causes of neonatal cholestasis in children. Third important cause will be metabolic, that is parenchymal liver disease. And there the most important causes are galactosemia and tyrosinemia. And fourth important cause is other systemic causes like hypothyroidism, hypopituitarism, and sepsis. Remember, you need not actually go on to look for torch infection in each and every case of neonatal cholestasis, because one, they are very rare. Second, only CMV is actually known to be commonly causing jaundice in the newborn period or in the infancy. The others are very rarely cause jaundice. So how do we now approach a case of neonatal cholestasis? Now, if you are dealing with a case of neonatal cholestasis, you need to first differentiate whether there is an obstruction to the biliary tree or it is an intrahepatic cholestasis. So if there is obstruction to the biliary tree, the bile cannot come down through the biliary tree into the intestine. So the stool will not have the pigment which comes due to the color which comes due to the bile. So stool will be acholic, or what we call pale color stools. And the most common cause of this is biliary atresia. In diagnosing biliary atresia is very important early on, because the surgery which is done for it is successful only if it is done, say within, usually within 2 to 3 months of age. So let's see it with an example of a case. Now this child who was admitted with us some time back, presented to us at 52 days of life. The child has progressive jaundice starting at day 6 of life, and the jaundice was progressive till the time of presentation to us. Stools were mostly pale, and the child had some bruises on the body which was representative of skin bleeds and which resolved after giving vitamin K. Now, this is the stool color of the child, and you can see that the stools are completely pale. It's always good to follow stool color charts. These are readily available on the internet and can be downloaded, printed, in color print can be done and can be pasted in your wards. So you can see that these two colors are consistent with abnormal stool colors. It's representative of a biliary obstruction. On examination, this child had firm liver, which suggests a chronic liver disease and splenomegaly, which in combination with firm hepatomegaly suggests presence of portal hypertension. So let's analyze this case. So this case, we have a case of neonatal cholestasis with dark urine and urine which was staining the diaper. So we are dealing with conjugated hyperbilirubinemia. The stools are acholic. So we are dealing with a biliary obstruction. There is vitamin K responsive bleed. So there is some cholestasis going on. We have ruled out other alternative causes of biliary obstruction like use of parenteral nutrition, hemolysis, which can cause inspissated bile, etc. And we have firm liver with splenomegaly on examination, which suggests chronic liver disease with portal hypertension. So on the basis of this, our diagnosis is going towards an obstructive biliary pathology, that is biliary atresia. Now, always remember to check for stool color yourself, because the parents may not be able to actually analyze and report the actual stool color to you. Facial dysmorphism is important in some conditions like Alagille syndrome, which are close differentials of biliary atresia. Eye examination is important in certain metabolic liver disease, but not in biliary obstruction. And skin and genitalia also need to be examined. So coming to the LFT of the above mentioned child, there is conjugated hyperbilirubinemia and there is elevation in GGT. Now GGT is, you all know, is a marker of a cholestatic liver disease. So elevated GGT, which should have been normal up to 38, and elevated GGT suggests biliary obstruction. Remember, in pediatrics, we don't go with alkaline phosphatase because alkaline phosphatase can be is normally quite high because of the ongoing growth spurt, as well as due to high prevalence of vitamin D deficiency in children. Therefore, we usually prefer to check GGT and not alkaline phosphatase in children. So this child, ultrasound was done and ultrasound was suggestive of biliary atresia. Just to summarize, if there is biliary obstruction, bile will not come down. So CBD will not be seen on ultrasonography. If the bile doesn't come down into the gallbladder, gallbladder will be very small. So gallbladder may not be seen, or if seen, it will be very small. And there will be poor contractility of GB. So on the basis of this, we are again suspecting biliary atresia. Now, should we do HIDA scan? This is something that we see a lot of patients coming with a report of HIDA scan. HIDA is basically a radioactive substance which is injected into the intravenously, and it is expected to enter the liver and then be excreted through the biliary tree into the small intestine. But remember, any kind of liver disease will have this delayed excretion of HIDA into the intestine, and so this may not be very beneficial. It has very low specificity. So almost every case of neonatal cholestasis, you will be getting a non-excretory HIDA. So this has almost been discarded from the modern day practice. It is as good as seeing the stool color. If you are finding acholic stool color, pale stool color, you are likely to get a non-excretory HIDA. So HIDA scans should be done away with. Should we do a liver biopsy in the above mentioned case? Yes, because liver biopsy has one of the highest accuracy for diagnosis of biliary atresia, 1, and 2, it has a prognostic role. So suppose there is already cirrhosis, then you would not go ahead and do surgery. You would advise liver transplantation. However, if the child doesn't have cirrhosis, then you can go ahead and do surgery for biliary atresia. The third important role of liver biopsy is to rule out alternate causes of neonatal cholestasis like Alagille syndrome, PFIC, sclerosing cholangitis, and sometimes CMV. So the child was diagnosed with biliary atresia based on liver biopsy finding. Apart from that, once diagnosis is confirmed, or if the diagnosis is in doubt, you can always do a cholangiogram. Cholangiogram means injecting dye directly into the gallbladder. So you can see here that one of the cases where histology was not clear, these are 3 different cases actually where histology was not clear. The first case, you can see that we have injected dye into the gallbladder and the dye has gone up into the left and right hepatic duct, common hepatic duct and common bile duct, and is coming into the intestine. So this child has proximal and distal bile duct patency. So he does not have biliary atresia. Second case, you can see the dye has been injected. It goes through the common bile duct into the intestine, but the dye doesn't go up into the common hepatic duct. So this is like obstruction of the common hepatic duct. This is called type 2 biliary atresia. And the third figure, you can see that the dye is remaining into the gallbladder, which is dysmorphic small gallbladder, and there is no bile duct seam. So that is type 3 biliary atresia, which is present in 95% of cases. So what do we do if you have biliary atresia? Yes, you have to refer to the pediatric surgeon who will operate the child. He'll remove all the biliary tree and he'll connect the jejunum directly to the porta so that the bile can drain into the intestine. So the child underwent Kasai, and you can see that the bilirubin has gone down within a couple of months. So that was about if you deal with acolic or fluctuating stool color. Now you can have the second group of children who have neonatal cholestasis, that is conjugated hyperbilirubinemia with pigmented stool. Now here there are two main types of causes. One, if the child is not sick, you may have endocrinal causes like congenital hypothyroidism, genetic intrahepatic cholestasis, and CMV. But if the child is sick in the sense he can be sick with infection, that is sepsis, there you should do the blood culture, urine culture, and treat with appropriate antibiotics. Or he could be sick with decompensated liver disease. By decompensation, I mean either ascites or hepatic encephalopathy. And here, remember three important causes: galactosemia, tyrosinemia, and fructose intolerance. And these three causes are important because they are the treatable causes. Most of the other causes you will not be able to treat, and they will most likely either die or will require liver transplantation early in the course. But what we need to emphasize on is to diagnose the treatable causes like hypothyroidism, galactosemia, tyrosinemia, HFI, sepsis, and urinary tract infection, so that you can alter the natural course and improve the outcomes. So let's take an example. A 3.5-month-old male child presented to us with jaundice since day 10 of life, again progressive jaundice. Now this child has decompensated with ascites since last 3 weeks. He's not growing well. He's having failure to thrive, and he's developed sepsis when he developed sepsis a few days before coming to us. So what we have a child with conjugated bilirubin who is decompensated with ascites and is sick with sepsis and has growth failure. On family history, there was a history of abortion and there is a history of a neonatal death at day 23 of life, suggesting that there could be some genetic metabolic liver disease. On examination, we have firm hepatomegaly, splenomegaly, and we have ascites. We also have presence of bilateral cataract. This is a typical finding of galactosemia, but you will not always find it. This is a prototype typical case which I am showing, but again in 50% of cases, you may not actually find cataract. So on the basis of this findings, we are dealing with possibly a genetic cause because we are dealing with a family history, and we have cataract, and we have a child who is on breastfeeding, so is receiving galactose. So we are likely thinking about a metabolic liver disease, possibly galactosemia. So how do we evaluate? We do the liver function test, and here we can see again there is conjugated hyperbilirubinemia. But important part is you should always also do a INR. Now INR here is 2.6. Remember, whenever you have a high INR that is more than 1.5, give 2 doses of vitamin K, 10 mg each, 6 hours apart, and then repeat the INR. If the INR doesn't improve with vitamin K, that means it is synthetic dysfunction of liver, because the coagulation factors 2, 7, 9, 10, factor 5, all these are deficient, and because of these coagulation factor deficiency, the INR will be prolonged. We can also see that another important albumin that is synthesized in the liver is low. So here the liver's synthetic function is deranged because of deranged INR and low albumin. And there is GGT is normal, suggesting there is no obstruction to the biliary tree here. So what do we have? We have a sick infant with pigmented stools. So we are dealing with a neonatal cholestasis, but intrahepatic cause because the stools are pigmented. We have a child who has ascites, low albumin, and high INR, suggestive of liver synthetic dysfunction. And we have markers to suggest a metabolic liver disease like family history, consanguinity, and history of sepsis. So how do we evaluate a sick child with neonatal cholestasis? As I showed previously that the child could be sick due to sepsis or due to a metabolic liver disease. So first step, you should do a metabolic screen and a septic screen. We all know the septic screen. It should include procalcitonin, which is considered a better marker of gram-negative infection presently. But what is important in metabolic screen is to identify the treatable causes. So we want to find out galactosemia, tyrosinemia, and HFI, fructose intolerance. So for galactosemia, we want to see hypoglycemia. We want to see for the presence of galactose or fructose in the urine, that is urine non-glucose reducing substance. And for tyrosinemia, we want to see for alpha fetoprotein. Now, how do we do the urine non-glucose reducing substance? As the name goes, we have to first show the presence of reducing substance and then prove that this reducing substance is not glucose. So for proving reducing substance, you do Benedict's test. So you do the Benedict's test, 5 ml of Benedict's solution has to be taken, 0.5 ml of urine has to be added, and it has to be heated over a burner. Now, green color is precipitate is 1+, orange is 2, and brick red is 3+. So you can see that one of this child has 1+ reducing substance and this child has 3+ reducing substance, that is brick red precipitate in the urine. Now, apart from this test only proves that there is some reducing substance in the urine, but this reducing substance has to be galactose or fructose. So you have to do urine for glucose. Now, this can be done by sending urine routine to lab, or you can do it bedside by using dipstick test. So if you get that Benedict's test is positive and urine for glucose is negative, that means you have found out urinary non-glucose reducing substance, which could be either galactose or fructose. But remember that when you are doing this test, child should be having regular galactose and fructose containing diet. Otherwise, you will get false negative result. Suppose the child is on galactose free diet like soya based diet or Semile MCT powder, then these tests are likely to be false negative. So on the basis of the first step, whatever is positive, suppose you get urine NGRS positive, that means you are dealing with either galactose or fructose. If alpha fetoprotein is positive, you are likely dealing with tyrosinemia. So on the basis of that, you have to send the confirmatory test. So for galactosemia, it is a GALT assay, that is the enzyme galactose 1-phosphate transpeptidase. So the GALT enzyme. And for tyrosinemia, it is urinary succinyl acetone. Remember, for sending GALT assay, GALT is the enzyme is assayed in the RBCs. So the patient should not have received blood transfusion in the previous 2 months. Otherwise, you cannot send GALT assay. For urinary succinyl acetone, it has to be sent in ice because succinyl acetone is a very volatile substance. And if not sent in ice and not processed within a few hours, it will again come falsely negative. And obviously, the final step or the third step is genetic sequencing, exome sequencing, which will give the 100% confirmed diagnosis in these cases. So in this case, we got urine NGRS positive, that is reducing substance positive and no glucose in urine RM. So we had urine NGRS positive. We sent GALT assay, which was 5 units per gram of hemoglobin. Normal is more than 15. So confirming the diagnosis of galactosemia, we shifted the child on lactose-free feeds, and over a follow-up of 4 to 5 months, the jaundice had resolved, the growth had picked up, and cataract, although had not resolved by now, is likely to resolve in near future or may require surgery later on. So this is about the most common causes of jaundice in infants or neonates. Now coming to the other group, that is jaundice in older children. So here we'll be dealing only with the liver disease. So we are dealing with conjugated hyperbilirubinemia, that is the child is present with dark urine. Apart from the jaundice that is visible in the eyes, the child will have dark urine. So now these will be either acute hepatitis or chronic liver disease. So how do you differentiate between acute hepatitis or chronic liver disease? Now, as the term goes, acute hepatitis is likely to be of shorter duration. Usually we expect jaundice for less than 6 months, but as you must be getting the cases of acute viral hepatitis right now and must be seeing that most of these cases usually present with jaundice of very short duration, like say 7 days, 15 days, or maybe maximum a month or so. So jaundice will be of very short duration. On examination, you will not find any signs of chronicity. That is, liver will be just palpable. It will be soft liver. You will not be able to feel the margins properly. So the margins will be ill-defined and spleen will not be palpable. This suggests that the liver is just in an acute hepatitis. Sometimes the liver may have tenderness. There may tender hepatomegaly may be there. How do you diagnose chronic liver disease? The other side. The jaundice will be usually more than 6 months, but not necessarily. You can diagnose chronic liver disease even with a jaundice of 1 month. What is important is you have to rely on hard clinical signs, that is presence of a firm liver which has well-defined margins with splenomegaly. So if you have a firm liver with splenomegaly with evidence of CLD stigmata like Palmar erythema or spider nevi, so then you are more or less dealing with a case of chronic liver disease, even if the duration of jaundice is say 1 month or less. Apart from that, child with chronic liver disease will have larger amount of ascites and will have evidence of, may have evidence of growth failure. Now in acute hepatitis, there is a second thing. Is the child just a case of acute hepatitis, or is the child in a case of acute liver failure? So always, whenever you get a child with acute hepatitis, with jaundice of short duration, soft liver, no splenomegaly, always look for evidence of hepatic encephalopathy. And the easiest sign, obviously the advanced stages of encephalopathy, when the child becomes irritable, unconscious, comatose, that is easy to identify. But you have to identify the child in early encephalopathy. The earliest signs of encephalopathy would be the change in behavior, change in sleep pattern. The child may not be sleeping or may be excessively sleepy. And you can give simple tasks to the child, like subtracting 7 from 100 every time. So he may not be able to do the complex tasks which he usually used to do previously. So look for hepatic encephalopathy and always check for at least 1 INR value. So if the INR is more than 1.5 with hepatic encephalopathy, you are dealing with a case of acute liver failure. Such children will require admission to hospital, whereas children with just acute hepatitis without encephalopathy with a normal INR can be treated on an OPD basis. So what are the common causes of acute hepatitis in India? 90% of time there will be viral hepatitis, and in them 95% of time there will be hepatitis A virus. You may all be seeing the epidemic of hepatitis A right now, and maybe getting a lot of cases of hepatitis A right now. So that is the most common cause of acute hepatitis in children. Apart from them, the second most common cause is drug-induced. Now here the most important causes are anti-tubercular drugs and antimicrobial drugs, apart from some anti-epileptics. Systemic infections like dengue, malaria, typhoid, but it's very rare to have jaundice in these, except maybe in dengue. And then in chronic liver disease, you have to remember 4 important causes: Wilson disease, autoimmune liver disease, viral hepatitis B, and progressive familial intrahepatic cholestasis, which can present in infancy or it can present in older child. So let's see a prototype case of acute viral hepatitis that we are seeing nowadays. The first and foremost history that you should take is history of prodrome. Now, prodrome means just prior to the onset of jaundice, you will have history of anorexia. Anorexia is the most important symptom which points towards the presence of viral hepatitis. So anorexia, that is loss of appetite just preceding the jaundice, is very typical of acute viral hepatitis. Apart from anorexia, there may be symptoms of fever, vomiting, and abdominal pain. Now, once the jaundice rises, it may continue to rise for some time and then fall. It can take a month to several months for the jaundice to subside. And sometimes it can follow a relapsing course, like in this child, where the jaundice increased, then decreased, and then there was a second peak in jaundice, and then thereafter it decreased. However, this child never developed encephalopathy, and his INR was always normal. Although the bilirubin is quite high, 19, 16. His enzymes, liver enzymes, SGOT and SGPT are quite high. But since his INR was normal, this child was not admitted in hospital. Confirmation of the diagnosis is requires you need to send 3 common viruses, that is IgM anti-HAV, IgM anti-HEV hepatitis E virus, and HBsAg and IgM anti-HBC, that is hepatitis B. And most likely you'll find HAV as in this case. Don't send IgG, it does not have any relevance in this acute setting. The second problem that you will find in such cases is that patient had jaundice, the jaundice was decreasing or maybe was static for some time. Then the parents go to some alternative medicine like homeopathic or Ayurvedic, or they just go to some quacks. They give some medicine, and when they give the medicine, you'll see sudden rise in bilirubin. Now that is viral hepatitis with superimposed drug-induced liver injury. Again, you should check for INR in those cases. If INR is normal, the patient can be treated on OPD basis. But if INR is elevated or encephalopathy is present, the child needs to be admitted. So the clues for acute viral hepatitis are presence of conjugated jaundice, presence of prodrome, that is anorexia preceding the jaundice, very high SGOT and SGPT. By very high, I mean more than thousands. Usually in the first week of illness, you will find it to be more than 1,000. Later on, it may go down, maybe in 200s, 300s or so. But in first week, it will be more than thousands. Viral marker for HAV was present, and this child has no evidence of liver failure, so he was not admitted. He was treated at home. Okay, so how do you manage a case of acute viral hepatitis? The first and foremost advice that we need to give to the parents, because almost each and every parents who come with their child with acute viral hepatitis are on restricted diet. So first important thing is you need to tell the parents that for viral hepatitis, whether it is hepatitis A or hepatitis E, we are not going to treat with any antiviral. Your child's body's immunity is going to fight against the virus. And so you need not restrict any diet, because what we see is the parents restrict the diet. They give sugarcane juice, they just give carbohydrates, they don't give protein, they don't give fat, and the child doesn't like, first thing, the child doesn't like the taste, then he may have some anorexia, so the child is not taking adequate oral intake, he starts losing weight, and then when his immunity is low, he goes into liver failure. So first and foremost, there is no role of dietary restriction, there is no role of fat restriction. They can take as much fat, as much protein as the child wants. Second is adequate hydration, because the child, if the bilirubin is very high, it can damage the kidneys. So adequate hydration. Always look for encephalopathy and look for INR, that is presence of coagulopathy. And if these two are, one of these is present, you need to admit the child. And if both these are not present and you want to you want to send the child home only on OPD treatment, the only and only medicine that you need to give is ursodeoxycholic acid, UDCA, at a dose of 15 to 20 mg per kg per day, along with a multivitamin. So your prescription should have only 2 drugs, UDCA and multivitamin. Your prescription should not have Li52, which is not proven to help in acute hepatitis. Your prescription should not have Hepamerge, and no other alternative medicines should be prescribed. So no dietary restrictions, ursodeoxycholic acid and multivitamins. Let's see, the second most common scenario is drug-induced liver injury. Now we had this 9-year-old child who had presented at an outside center with fever and cough of 3 months duration. He was evaluated and he was confirmed as a case of pulmonary tuberculosis on basis of gene expert in sputum. He was started on 4-drug ATT, and then when he came to us, there was history of nausea and vomiting for last 3 days. This was 1 month after the initiation of ATT. When we sent the LFT, we immediately stopped the ATT and sent the LFT. Now LFT, you can see there is conjugated jaundice. SGOT and SGPT, that is AST and ALT, are more than thousands. INR is normal, so we are not much worried. That means liver synthetic function is okay. Child is not in liver failure. If it was more than 1.5, we would have admitted the child again and managed as a case of acute liver failure. And since this is a case of this looks like a case of acute hepatitis with very high enzymes, short duration of jaundice, that is 7 days. We also ruled out other causes, that is causes of viral hepatitis like IgM HAV, IgM HEV, HBs AG, and IgM anti-HBC, that is hepatitis A, E, and B were negative. So we can confidently say that this is possibly due to tuberculosis and anti-tubercular drugs. So whenever you deal with anti-tubercular drug induced liver injury, it's best to stop H, R, and Z. You should continue with ethambutol and add another drug, possibly levofloxacin is the drug which we prefer, and another non-hepatotoxic drug can be added. Once the enzymes normalize and the jaundice resolves, you can add rifampicin and isoniazid one after another, starting with a lower dose and increasing gradually under LFT monitoring. Pyrazinamide may not be added every time because it is the most hepatotoxic drugs, and in those cases you have to give pyrazinamide free anti-tubercular therapy, which has to be given for a longer duration. So the drugs which cause drug-induced liver injury, the most common implicated drugs in India are anti-tubercular drugs. In Western population, it is the antimicrobials. Apart from that, there are anti-epileptic drugs, and another very important category in India are use of this Ayurvedic drugs, herbal drugs, which are known to cause drug-induced liver injury. Okay, so now let's see some of the systemic infections which you may be finding, where although the jaundice is rare, but some of these cases can have jaundice. So first coming to typhoid hepatitis. Now jaundice is rare in typhoid hepatitis. If present, it can present in only 3 to 5% of cases, and if present, it presents in the second week. Jaundice presents in the second week. Important to remember, typhoid can be as a co-infection with hepatitis A, because both of these are transmitted through fecal-oral route. So both of the child can have co-infection with typhoid as well as hepatitis A. If it is just enteric fever, the transaminases will not be elevated very high. They will be just about 100 to 200, not beyond that. If it's going in thousands, you have to suspect a hepatotropic virus like hepatitis A or E, which may be causing co-infection and may have similar incubation period as typhoid. Jaundice usually starts in the second week if present, and is usually self-limiting, and if the enteric fever is treated adequately. Obviously, diagnosis is based on blood culture in first week and antibody-based studies on the second week. Coming to leptospirosis, again, less common, but in 5 to 15% cases of leptospirosis, jaundice can be present. An important clue to diagnosis of leptospirosis is presence of renal failure. So if there is simultaneous liver and renal involvement with fever, then you have to suspect leptospirosis. Again, the diagnosis is based on antibody-based tests, and treatment is with appropriate antimicrobials. Coming to malarial hepatopathy, even more rare to find jaundice, but in severe cases with Plasmodium falciparum infection, there can be presence of jaundice. Again, adequate treatment of malaria will usually resolve jaundice in these cases. Now, the most important among the systemic infection is dengue fever. Now, this is one which we commonly encounter. Now, these patients may not actually present with jaundice, but because of dengue, when there is a lot of third spacing and fluid deficit, these patients will have ischemic insult to the liver, resulting in very high transaminases. AST and ALT we found in several thousands, like AST may be up to 5 to 10,000, ALT may be again up to 3 to 5,000. So a very high AST and ALT, where AST is more than ALT, that is SGOT is more than SGPT. Now that is seen in ischemic liver injury, will make you suspect the presence of dengue, and these children can go into acute liver failure. So if we are finding very high raised transaminases, SGOT, SGPT in a case of dengue fever, suspect that there is ischemic hepatitis, check INR, rule out acute liver failure. In any case, whether there is acute liver failure, or there is ischemic hepatitis not causing acute liver failure, you should immediately initiate treatment with injectable N-acetylcysteine. The dose is 150 mg per kg day 1 and 100 mg per kg per day thereafter. Okay, so that was about acute hepatitis, that is viral hepatitis, and systemic infections presenting with acute hepatitis. Now I'll just quickly go through the chronic liver disease because I think we have less time remaining. So among the common chronic liver disease are Wilson disease, which has very wide types of manifestation. It can just be asymptomatic. It can present with fatty liver. It can present with chronic hepatitis. It can present with cirrhosis, or it can present like acute liver failure. Important is for diagnosis, you need to do 3 things. Serum ceruloplasmin. If it is less than 10 or less than 0.1 gram per liter or 10 mg per deciliter, that is strongly suggestive of Wilson disease. Second thing, you should do 24 hours urinary copper. You should advise the parents properly how to collect the urine. Like if you are doing from 8 a.m. to 8 a.m., the day 1 8 a.m. urine has to be passed in the washroom, not to be collected. And day 2, at the end of the collection, 8 a.m. urine has to be passed in the container. So 24 hours complete urine collection has to be there. And if it is more than 100, is strongly suggestive of Wilson disease. The third important thing is presence of KF ring, which can only be seen on, which can be better seen on slit lamp, but can also be seen on torchlight. So 3 things: serum ceruloplasmin, 24 hours urine copper, and KF ring have to be done. And if all 3 are present, diagnosis, or if 2 out of 3 are present, even then the diagnosis is usually confirmed if it is ceruloplasmin and urinary copper. Here it is written more than 40, more than 100 is strongly suggestive. The second most important cause of chronic liver disease is autoimmune hepatitis. Typically, you'll find girl children, adolescent, or maybe around 10 to 18 years of age presenting with recurrent episodes of jaundice. So whenever you are having recurrent episodes of jaundice, suspect an autoimmune etiology, and the clues to diagnosis of autoimmune hepatitis will be here, because there is an excessive immune activation. So what happens? Immunoglobulins are increased. So you can see here the LFT. Bilirubin is 10, direct is 7, total protein is 7.8, and albumin is 2, globulin is 5.8. Normally we expect albumin to globulin ratio of 2:1. But here you can see that albumin is low and globulin fraction is increased. That means that immunoglobulin fraction is increased. So reversal of AG ratio is strongly suggestive of raised immunoglobulins, strongly suggestive of autoimmune hepatitis. And whenever you are suspecting autoimmune hepatitis, you should do 3 things. One is IgG level, immunoglobulin G level, which is normal up to 13, or in some labs up to 16. So this will definitely be elevated. You should do autoimmune markers, that is ANA, asthma, anti-LKM1. Anti-LKM1 should always be done, because in children, anti-LKM1 positive autoimmune hepatitis, that is type 2 autoimmune hepatitis, is more common than type 1 autoimmune hepatitis. And the third important test that you should do is liver biopsy, because on the basis of liver biopsy only you can be quite confirmed about the diagnosis. And you should rule out other causes like viral hepatitis. So you have a simplified score. I'll not go into the score, but you need to do IgG, autoantibodies, liver biopsy, and rule out viral causes to establish a diagnosis of autoimmune hepatitis. Treatment of autoimmune hepatitis is simple. You start with 2 mg per kg of steroids. Once the LFT comes down, you taper down the steroid to up to 2.5 or 5 mg and add another long-term immunosuppression, usually azathioprine. We usually give UDCA till the time jaundice is there. I'd just like to end by saying about the analysis of LFT that you commonly find in your day-to-day practice. SGOT and SGPT, also known as AST and ALT, are released from the hepatocytes. So if AST and ALT are raised, that means there is some injury to the hepatocytes. There is hepatocellular damage. If there is rise in GGT, gamma GT, that indicates biliary obstruction. Alkaline phosphatase, although indicates biliary obstruction, should not be done in children, should not be interpreted in children as such for liver disease. And bile acids is another test that you should do, which will be elevated in any case of biliary biliary obstruction. So take home points. Always, whenever you get a case of jaundice in OPD, try to classify it as conjugated or unconjugated based on presence of normal colored urine or high colored urine and presence of direct or indirect hyperbilirubinemia. If you are dealing with a neonatal cholestasis, you will find conjugated bilirubin, unlike neonatal jaundice where it will be indirect hyperbilirubinemia. Classify the causes based on stool color, so that is biliary obstruction, and in the basis of decompensation, that is metabolic liver disease. Try to streamline evaluation based on flowchart as I have shown previously. Always try to identify the treatable causes which require urgent diagnosis and treatment, mainly which are biliary atresia, galactosemia, tyrosinemia, HFI, sepsis, and hypothyroidism. And stepwise workup would be beneficial because otherwise you will be lost in the maze. For the older children, always when you are dealing with a case of acute hepatitis, always rule out liver failure by identifying encephalopathy and by checking INR. If they are normal, you can treat on OPD basis. If encephalopathy is present or INR is high, treat on IPD basis. The main drug that is used is N-acetylcysteine IV. Advanced cases will require liver transplantation. Always look for signs of underlying chronic liver disease, and that would be a firm hepatomegaly with splenomegaly, irrespective of the duration of the illness. And viral hepatitis doesn't require any specific treatment unless there is liver failure, and drug-induced liver injury should always be kept as a realistic possibility in almost all cases of acute hepatitis. Thank you. We can take any questions if you wish.
Yeah, thank you, Dr. Bikrant, for such a nice lecture. Now, I don't think there are any questions in the chat box. If there are any questions, Dr. Chaurasiya, please take up the questions.
So one question in chat box. Sir, so first of all, thank you, sir. You have given a wonderful presentation. In short time, full package of jaundice in children. How to approach, how to treat, and there are some very important, simple messages. No dietary restriction, no hepamers at all. These are very common scenario. Whenever we said our patient that jaundice, then they are searching for sugarcane juice, etc., etc. So it's very simple and very excellent presentation. So, sir, one question in chat box: how many copy number of CMV PCR should be considered significant for consideration of antiviral therapy in neonate with cholestatic jaundice? And question in context of urinary CMV PCR.
Now, there is no cutoff as such for level of CMV that is present in urine or in liver tissue that needs to be treated with antiviral, but any positive CMV PCR with clinical manifestation would need to be treated with antiviral. However, just positive CMV PCR without symptoms or without manifestations would not warrant an antiviral therapy in absence of symptoms.
Yes.
Okay, Dr. Bikrant, just...
Yes.
Okay, thank you, Dr. Chaurasiya. I am just myself have one query. Routinely, should we test all the children coming in OPD with jaundice for hepatitis A virus antibodies, because it's a relatively costlier test and it may not be possible for testing all the patients coming with jaundice for HAV, acute hepatitis in OPD, especially in the government sector?
Yes, sir. I agree completely with you that if the symptoms are suggestive of acute hepatitis, that is short duration of jaundice with prodrome, we are expecting viral hepatitis, and making a diagnosis of acute viral hepatitis will not change the treatment because we are not going to give any specific antiviral therapy. So yes, I agree with you. In resource limited setting, doing the antiviral test may not be very beneficial, but in our setting we do it. But yes, you can always avoid doing that, and you can just test for INR to be sure that the child is not in liver failure and doesn't require admission.
Yeah. Second thing, in my personal experience, what I have seen, the patients we saw in OPD, and after 3-4 days, he landed up with encephalopathy in our emergency. So constipation is a very important precipitating factor. And retrospectively, when we reviewed the history, constipation is present in most of the patients. So should we advise the parents to give laxatives if there is constipation in the course of the illness to avoid precipitating encephalopathy, or it's just coincidence that they are having constipation, because it's a known factor for precipitating encephalopathy. So what is the role of laxatives in the management of hepatitis?
So I'll completely agree with you on this point, sir, that constipation is a known precipitant for because of constipation, there'll be increase in ammonia and that will precipitate encephalopathy. So laxatives can be given in each and, but again, we usually don't give laxatives to each and every case, but giving it also may not cause any harm because the laxatives do not have as such many adverse effects, especially the polyethylene glycol ones do not have too many adverse, do not have any adverse effects actually. So they can be used apart. So I mentioned that our prescription usually has UDCA and multivitamin. So yes, it can include polyethylene glycol also, but usually children who are going into liver failure, that is those who have INR more than 1.5, these are the children more likely to develop encephalopathy even if precipitated by constipation. So that's why it becomes very important to check for INR at least at the first admission. Usually the children who are having normal INR, we have not seen them going into encephalopathy later on in the next 1 week or 10 days. They don't go into encephalopathy. It has not happened that way.
Okay. Plus, actually, use of N-acetylcysteine in dengue ALF is news to me. I was not aware that we can use this medicine for dengue ALF, because dengue is very common in our area in Noida. So what is your experience regarding this use of this medicine in dengue ALF? It's not very commonly used medicine.
That is the only thing available that we can give for, like if dengue leads to dengue shock syndrome, if the child is presenting with elevated enzymes, even if the child is not in liver failure, if it's a case of ischemic hepatitis, even then there is an indication for using N-acetylcysteine, because N-acetylcysteine is known to improve ischemic hepatitis. And if the child has gone into liver failure, then that itself is an indication for use of N-acetylcysteine. In any case, we do not have any other drug to treat liver failure in these children. So N-acetylcysteine definitely has to be used in all these children.
Okay. So I will use in our next few patients and then let you know. Dr. Chaurasiya, if you have any comments.
We get the referrals for, we get many of the children who are initially admitted for dengue elsewhere, and then they are shifted to our place when they develop liver failure. Again, we have only this, NAC as the only drug. Apart from that symptomatic treatment, NAC is the only thing. Vitamin K you can give if INR is high, always give vitamin K, but then we do not have too many drugs. If the child is not improving, we are going towards a liver transplantation. So yes, we should use NAC in almost every case.
Dr. Chaurasiya, please take up the questions in chat box. Dr. Chaurasiya?
There is one more question.
Yeah.
What all should be advised as baseline investigation in older child with jaundice?
What all should be advised? Older child, that again becomes a very vague thing. If the child is presenting with jaundice, I think first thing, older child, I want to take the history, whether it is acute hepatitis or chronic liver disease. And if the diagnosis, if the history is not clear, then I'd first do LFT and INR. This will be my first 3 tests will be hemogram, a complete hemogram with peripheral smear, liver biochemical test, that is liver function test, and the INR. And depending on what I am dealing with, based on these tests and on history, then I will do the further test. If I'm dealing with chronic liver disease, I will do workup of Wilson, autoimmune, and hepatitis B and C. If I'm dealing with acute hepatitis, I will do workup of viral, I'll send viral markers. So depending on the first line test and history, I would do the further test.
Yes. Thank you, sir. I think there is no more question in chat box.
Dr. Bikrant, please stop sharing the slides.
Yes, sir.
So, with the permission of the chairpersons, can we close the session?
Please, it was a very informative session, Dr. Salam.
I think Dr. Bikrant, congratulations and thanks so much for giving such a wonderful talk. I think it was such a concise talk and still covering from neonatal to the older children, from the acute to the chronic, from all systemic causes of the jaundice. apart from the infective. I think anyone who is listening to this talk, I think if he gets a PG, he gets a case of jaundice, he can very able to build up that case and present his case in his postgraduate examination. I think we will like to preserve this case and this talk on our AOP UP channel, YouTube channel, and so that our postgraduates can view this talk again and again and telling about it. And also about concluding remarks, I'll invite Dr. Ajay Shrivastava, Secretary of the AOP UP. Dr. Ajay. Dr. Ajay Shrivastava. Probably is still not around. So thank you once again, Dr. Bikrant. Thank you, Dr. DK Singh. Thank you, Dr. Om. I think all the postgraduates, I must thank you because of your patronage and your cooperation. All the faculty members and the practitioners also, I'm seeing in the large numbers who have joined here this time. I think this because of the topic, which is so good, and Dr. Bikrant has done so much. Presented it so wonderfully. I think everybody must have realized how wonderful the talk was. Thank you all who have joined. And next week, we have very, very interesting, very important. No postgraduate would like to miss that session. That is the examination of nervous system by a very accomplished neurologist. He will be taking this examination of nervous system in two parts. Part 1 will take on 29th and part 2 on 5th of August. So then see you next Friday. Thank you again.
Okay. Thank you. Thank you, Dr. Sir. Thank you. Bye.